Well, good afternoon, everyone. It is 1 o'clock, so we will go ahead and get started. Welcome to Georgia Memory Net webinar series, co-sponsored by Urban Health Initiative. Today's guest speaker is Dr. Reuben Warren of Tuskegee University. Our topic will be aging and sickness may be associated, but they are not the same. My name is Brittany Prince Evans, and I serve as the engagement manager for Georgia Memory Net and the assistant director for Urban Health Initiative. So today I'm wearing not one hat, but two hats. Georgia Memory Net is a certified program dedicated to early diagnosis and treatment of Alzheimer's disease and related dementias. Urban Health Initiative mission is to provide health disparities, education, and advocacy, build collaborative partnerships, and develop best practice models with low resource communities and those who work with them to advance equity in health and well-being. I am so honored to introduce Dr. Warren, whom I had the pleasure to work with on several different projects with Urban Health Initiative. Dr. Reuben Warren is the director of the National Center of Bioethics and Research and Healthcare and a professor of bioethics at Tuskegee University in Tuskegee, Alabama. His extensive public health experience at community, state, local, national, and international levels range from clinical and research work in the Lagos University Teaching Hospital in Lagos, Nigeria, to heading the public health dentistry program at the Mississippi State Department of Health. Dr. Warren has contributed to the scientific literature in public health, oral health, ethics, and health services research. His professional associations include the Health Brain Trust of the Congressional Black Caucus of the United States, National Dental Association, American Board of Dental Public Health, American Public Health Association, United Nations Children's Fund, and World Health Organization. Dr. Warren's membership in health-related associations has expanded his perspective on health. In 1996 through 1997, Dr. Warren served as chairperson of the Caucus of Public Health and Faith Communities, an affiliate of American Public Health Association. Without further ado, I introduce Dr. Reuben Warren.
Good morning. Can everybody hear me?
Yes.
Okay, great. Well, it's a pleasure to talk with you, and I hope we're having a conversation rather than a quote-unquote lecture. I've had too many lectures. I'm sure most of you have as well. And I always start off when working with Charles Morris to really kind of applaud the kind of work that he's doing, both in the office, in the hospital, and more importantly, outside of the office, in the hospital, in the community. So this is an honor to really continue to work with him and really get a chance to meet, by virtue of nothing else, the many people and organizations that he's working with. You heard about my initial topic, aging and sickness may be associated, but they are not the same. And I've been wrestling with that notion as I become older and react to people treating me like I'm getting sicker, and assume things that I can't do, in opposed to realizing the things that I can do. And I am really paused and at times frustrated by folks doing things for me instead of doing things with me. I'm sure you've had some of those experiences yourself. But in this day and time with the coronavirus pushing everybody to boundaries that they've never been, I had to switch my topic. And I'll deal with the whole issue of sickness and illness and disease, but a more pressing topic, in my view, really is framed around building trust in an untrustworthy environment. Building trust in an untrustworthy environment. And I say that because we're all paused as we watch the coronavirus spread beyond control. And the measures that seemingly have no foundation in science seem to be working in reality. And I'm struck by the fact that people will not accept very basic behaviors like washing your hands, like wearing a mask, like social, well, not social, but physical distancing, because it seems too easy to be effective. So intertwined with all of my comments is in the context of the public health ethics crisis we find ourselves. It started off as a public health crisis, and it evolved into a medical crisis. And I would argue now that it's a public health ethics crisis because we could have done better, and for whatever reasons, we didn't. The foundation of my work really is around this whole very challenging disease of Alzheimer's. And I take it very personally because April 9th of this year, a very dear friend, Dr. Bayless Walker, died from coronavirus. But he was having some dementia challenges which aggravated both the disease and the treatment of the disease. Bayless Walker, some of you may know, was a giant in public health, the past president of the American Public Health Association, former dean of the School of Public Health in Oklahoma, a head of health department in Michigan and in Massachusetts, and recently retired as a full professor of occupational and environmental health at Howard University College of Medicine. I had just talked with Dr. Walker about 3 weeks earlier, and his caregiver in Washington called and said that he died. And it was shocking because I just talked with him about doing some things. And as I listened to her, she said his challenge was because he would not comply with the mask. She'd put it on him and he'd take it off. She'd put it on him again and he'd take it off. So that intersectionality between Alzheimer's and other kinds of conditions. That's one pause. The other pause is my mother, whom I died in 2009, that was challenged with Alzheimer's disease herself. And I walked through that on a daily, minute, hourly basis for about 4 years that I could recall specifically about the challenges that she had and the challenges we had in trying to give her the best quality of life that was possible. So that's the context of my work. And much of what I do, and I've been working in the area of quote unquote minority health for some time, minority public health for some time, and the statistics, the data, the epidemiology, the numbers have a name. And unfortunately, for some of us, we know those names personally. We know them personally. So that's kind of the context of what I want to talk to you about, or the context from which I want to have this conversation. The issue of Alzheimer's and its relationship to the African American community in particular is quite new to many of us. I've been working in areas of minority health for at least 30 or 40 years, and I was unaware until a few years ago the disproportionate impact that Alzheimer's is having on the African American community to a large degree, and on Hispanic communities to a lesser degree. So the premise, if you will, of my conversation, of our conversation, is the following. Compared to other groups, African Americans experience a significantly greater impact from Alzheimer's disease than other health challenges. African Americans are diagnosed, are more healthier when they're diagnosed. The consequence of the subsequent challenges are more than other populations, and yet we don't talk about it enough in the context of the African American populations. That's the premise of the first premise of this conversation, that African Americans experience a significant greater impact of Alzheimer's than other populations. The second premise is that compared to other groups, African Americans are less likely to participate in clinical trials and in human subject research in general. And there's a long literature, we won't belabor it, about the relationship between human subject research and the African American population, going back many, many years, and in fact, going back centuries of abuse of African Americans and the research community. So we're less likely to participate in clinical trials, and we've done some work on that issue that I'll share with you later on in my comments. The third premise is that based on documented evidence, years and years, there's a legitimate distrust in the research community by the African American population. And I say legitimate because you all surely will have heard of the quote unquote Tuskegee Syphilis study and its disproportionate impact on African American men, their families, and the African American community. Let me start by clearing up the first misnomer, as that's the name. It is classically known as the Tuskegee Syphilis study, but in fact, it was United States Public Health Service syphilis study at Tuskegee. And I think that name, understanding the name change, is critical to understanding the impact of that condition, of that research endeavor. And based upon those three very important premises, I would argue that anything that we do, research, education, or community engagement, has to have the understanding, must understand that those premises invade, in fact, underlie a lot of the quote unquote compliance or non-compliance of African Americans around issues of Alzheimer's and other health disparities. Those are the three premises from which I want to have this conversation. And I spent 20 plus years at the Centers for Disease Control and Prevention in Atlanta as Associate Director for Minority Health. And in that time period, it became clear to me that there's a systematic, disproportionate burden that African Americans and other minority populations have on the common preventable diseases, conditions that we all should not have to live with disproportionate impact. In 1985, the Secretary's Task Force on Black and Minority Health published a landmark document that chronicled that you could measure disease, morbidity, and mortality based upon race and ethnicity, not caused by race and ethnicity. And that report was the first time that the federal government acknowledged that there was the disparity that be literally counted based on race. The Secretary's Task Force report on Black and Minority Health, 1985. In that report, they chronicled 60,000 excess deaths experienced by African Americans. Excess deaths are simply the number of additional preventable unnecessary deaths in the African American population, regardless of age, compared to their non-Hispanic white population. In 1985, that number was 60,000 excess needless deaths. Now that was a revelation for the nation, if not for many of us in the research community. And so at that time, change. There was legislation at the federal level, at the state level, at the local level. In the academy, they established specific strategies to address both research, education, and community engagement related to eliminating the disproportionate burden of disease disparity in the African American community. Before then, it was just a number. After then, it became what we had hoped to be an initiative. And there was excitement. In fact, I was in the academy at that time, and I left to join CDC to direct the Office of Minority Health. And we were excited at the federal level, at the state level, at the local level, because we thought we could make a difference. There was a lot of money, a lot of so-called commitment, a lot of research to really reduce, they said at first, and eliminate ultimately those disparities. And at that time, the word health had not even been created. Called it a difference, different disease difference that could be chronicled by race or ethnicity. So it was exciting. We were doing things and connecting, and in fact, there were 39 offices of minority health in the states, and there were 39 states that have offices of minority health specifically dealing with African American health or health disparities, Hispanic, Asian American, and Pacific Islanders, Native American, and Alaska Native strategies. We were excited, a lot of money was spent, a lot of papers were published, and we thought we were making a measurable difference. But in 2005, Satcher et al. Went back and used the same method and analyzed the data to see if we had really made a difference. And those 60,000 excess deaths had risen to 83,000. So we went from 60,000 excess deaths to 83,000 excess deaths. Embarrassing, frustrating, and really disappointing. Spent more money, spent more time, and in fact, had not made a difference. And in fact, it had gotten worse. And interestingly, those excesses were due in part specifically to HIV and AIDS and to homicide within the African-American population, specifically African-American men. Now, I say that to contextualize Alzheimer's disease. I say that in intention to contextualize the coronavirus and what is happening, what the data are telling us about that condition as well. So what I hope you're hearing early on in my conversation is that not much has changed. Not much has changed. If you look at it epidemiologically, not much has changed. And in fact, it may have gotten worse. Let's talk specifically about this thing called Alzheimer's and what do we know and what are we doing? The work that I had done prior to maybe 2 years ago, 3 years ago, I had not really understood the impact of Alzheimer's in the African-American population. It was surprising to really see what the disease was doing unknowingly. The research community was doing work, but it had not reached a level where there was a community demand to do more and do differently. So we began to kind of talk about what do we do and how do we do it. And out of that, several research endeavors evolved, and I want to share a couple of those with you. And the premise again of this work is not defining the problem again, not being surprised by its disproportionate impact on the African-American community, but really trying to say, what are we going to do? My work at Tuskegee is in the National Center for Bioethics and Research in Healthcare, and we shifted the paradigm for looking at bioethics as a foundation for the work, though it is important, to shift to public health ethics as a more expanded population-based enterprise. As you probably know, bioethics deals with autonomy, it deals with benevolence and justice. Very, very important foundations, very important constructs. And that is specifically in our context with health and healthcare system, the relationship between the doctor and the patient, both individually and collectively. And also, in addition to the doctor-patient relationship, is how those disproportionate impacts in research and healthcare delivery impact on the individual. That's the foundation for bioethics as it's being currently practiced. And autonomy being first, and then benevolence. And benevolence is simply the intention to do good, the intention to do good. So we try to reach back and say, is the research community trying to do the right thing? And how do we measure that? And out of that came IRBs, because they're really not, the IRB is really to look and see if we're doing the appropriate thing in the appropriate way. Doing the right things and doing things right is the foundation for IRBs. And third is justice. And justice is simply, as difficult as it may be to practice, simply it's fairness. How do you operate fairly? And that shift we made from bioethics to expand into public health ethics, and public health ethics is founded on the premise of not autonomy only, but community engagement. How do we have the early conversations about what we do, when do we engage, how do we do it, how do we measure our impact, and what does it mean in the larger picture of population health? So it really, out of that came the whole notion of community-based participatory research. It really talks about early engagement with community if you want to have an impact in that community. So we've gone from autonomy to community engagement, not either or, but both and. And around the issue of benevolence, we argue in public health ethics that it's beneficence. That's what do you intend to do, But what in fact are you going to do? What have you done? The doing of good, not the intention to do good. But we're shifting to include the intention, but also some measurable way to determine the outcome of your intention. So it's benevolence. We've gone from beneficence to benevolence, from benevolence to beneficence. And it's important to distinguish between the two. And the last is social justice, and that's beyond the individual. It's population-based health. And for me, social justice and public health are quite synonymous. So you see, we've shifted, and if we put Alzheimer's disease condition in that context, then we'll find there's some really important things that we can and we must do. So let's talk about what must we do, not what do we intend to do, but what must we do. And the first one, and I think the most important one, is to build trustworthy relationships. Now, any of you that have been working in science at any level, from the bench to the community, know the importance of trust. And we always ask, particularly in communities of color, to trust us, to trust me. And the proposition. But unfortunately, there's a sound and long, painful history of the research community and the community at large not being trustworthy. So we argue that don't ask to be trusted, develop trustworthiness, and trust will follow. They are very, very different premises. Trustworthiness is what ought to be pursued and not only trust. Develop trustworthiness and trust will follow. And building trustworthiness takes time. You don't go to community and ask them to trust you or to engage with you when you want something. You must do that long before you want to, before you want something, and the engagement becomes more important and more long lasting. So think about trustworthiness as we think about trust. Different paradigm, but in a very important one. The second one is developing and implementing strategies and programs that engage community. That goes back to our first construct of public health ethics. When do you engage community? First and foremost, how do you define community? I would ask you to pause and say, well, when I say community, what comes to your mind? And for many of us, if not most of us, you think about communities of color, you think about low-income communities, you think about communities of tremendous need. And I would argue that there are kinds of communities. And it seems to me that it's important to define the community, who the important stakeholders are, and engage them in an interactive and an interactive process that allows open and honest conversation. So we got to talk about developing relationships early on if we expect any long-lasting trust to continue. And the implementation process ought to engage who do we want to do it, what do we want to do, and what does it take to make it happen? That's a notion of coordination. So we all want to implement a program, but the most important part of implementing that program is the coordination and those players that are critically important. We've talked about trustworthiness. We've talked about developing and implementing trust and how long does it take. And thirdly, is some measure of assessment. And I'm being clear, I'm real clear, the difference between assessment and evaluation. The assessment simply says what's happening, what do we measure, what's going on. The evaluation is a more quantitative and value judgment measure done with a different level of specificity and preciseness. So we have to talk about assessment that's without judgment versus evaluation. And evaluation comes along the lines, but assessment must precede that. The fourth aim is really the evaluation. How do we measure what it is that we want to do? And I'm suggesting that evaluation has to be objective and quantifiable. It must include input. What are you putting in to get something out? What are you inputting to get something out? The second is performance. How do we measure what we put in? How do we measure what we put in? And how do we determine what we're getting out? So performance, What are you getting out? And then thirdly, the adequacy of performance. Was it enough? Sometimes we can have a success, but the success is not significant enough difference. So don't talk about just the success that you're having, but was that success adequate enough to meet the need? So we have input, we have input, we have performance, adequacy of performance, and then we have, at last and most importantly, the evaluation. How do we measure the outcome? How do we measure the outcome? And then, of course, the last piece of that is the administrative piece that makes all programs work or not work. Now, what do we do with this Alzheimer's in the context of the coronavirus? How do we begin to talk about this Alzheimer's condition in the context of the coronavirus? I think that's a challenge for us. And what we heard early on was that the coronavirus was impacting upon over 65, those at risk, if you will, and those with preconditions. And what we're finding out now, that those at risk were simply not because of their age particularly, but because of the circumstances they found themselves. Not because of their age particularly, but in circumstances they found themselves. And we also argue that the at-risk populations was those people with continuing chronic conditions, diabetes, heart disease, other conditions that put them at greater risk. And what we found when we looked at the data was, while that is true, the current circumstances, having to go to work, having to work in very difficult circumstances, was the creation of continual risk that far outweighed the quote-unquote chronic risk from heart disease and diabetes. So we got a challenge before us. How do we want to do in the context of ourselves? I'm want to kind of conclude my comments about Alzheimer's with a challenge to you. How do you place this condition called Alzheimer's in the circumstance of where we find ourselves, particularly as it impacts upon minority populations? We're dying at a greater rate from all conditions, and we're dying at a preventable rate from other conditions. And I would suggest that we think about Alzheimer's in the context of a microcosm in a macrocosm. This condition puts it at greater risk for other conditions. And I'm hoping that we can have a conversation about how do we balance the need and the challenge with the resources and commitment. So let me conclude by hoping you have some questions that could challenge me to, in fact, in turn, challenge you.
Thank you, Dr. Warren, for your presentation. As always, you inspire me to be a change agent in the community, and I encourage everyone to type any questions or comments in the chat box below. And I'm just checking the chat box. So I guess I'll go by my first question. You used to discuss about building trust in the community. So having this relationship, how do you encourage us to build a relationship in the community when we currently cannot go out into the community right now?
Well, I think that the 2020 makes it much easier. For example, you hear the notion of the public health recommendation of social distancing. I think it's a false notion, because social distancing brings about isolation. Isolation brings about other kind of challenges, including mental health challenges. I think the shift is physical distancing, not social distancing. And physical distancing just means you're not face to face, but you've got the media, the social media, you've got all the other tools that we've used in the past to stay in contact. So social distancing is, I think, not a full exploration of what we ought to be doing. Physical distancing, and then we reach out the way we do anyway. We have a social media network in this country, if not the world, that's phenomenal. Instant replay, the good, the bad, and the ugly. So shift that and just enhance the social, and I would argue spiritual connection that brings people closer together more often. I've been on remote work schedule since March the 23rd, and I've been out of my yard 4 times. but the connection that I've had, the telephone calls, the email traffic, probably too much email, has placed me in more interactive positions with people than I was when we didn't have the shutdown. So focus on physical distancing, and that's a must. That's an absolute, and enhance at the same time the social and spiritual connections.
Thank you. And so we have a question, well, a comment from Dr. Ted Johnson saying that we have been talking about the differences between social distancing and physical distancing. And I agree with your assessment, and physical distancing is the more relevant term. Thank you, Dr. Johnson. Another question that I have for you while I wait for others to type questions, concerns in the chat box below. I know that you have a background with the faith-based community as well, and I think one of your degrees is in religion, and I feel like using the churches maybe can be like one resource that some organizations may not use, and want to you discuss on what are ways that we can utilize the faith-based community with research or even with discussing dementia.
Yeah. I talked about earlier trustworthiness, and the painful part about engaging the faith community is that that's been an old strategy, and in fact not a good one, because it's been used for not good reasons. I mentioned the U.S. Public Health Service Syphilis study at Tuskegee. The first place that the scientists went to engage the Black community in rural Alabama was the church, because that is a trusted institution. And therefore, they went to the church and convinced the leadership that they were doing trustworthy work, trustworthy things. And therefore, the pastor with his leadership role, with her leadership role, said it's okay. And therefore, the congregation, the community began to engage. And what in fact was an unethical strategy to engage the population in research. So we need to engage the faith community, but as equal and equitable partners, and realize in the context of research, historically, researchers have gone to the faith community, to the churches, particularly when they wanted to convince folks to engage in research. So don't go when you want something. You want something and you need something, and build relationships with the leadership. That is particularly in the African American community, we are the most religious group in this country, either directly or indirectly by our parents, our grandparents. And that is building a trustworthy relationship with folks that we trust.
Thank you. And we have a comment from Dr. Carolyn Amen. She said, yes, we are physically distanced and more socially connected than ever. Let's find a way to change this unfortunate old pandemic language. How to start a language change movement.
Yeah, let me speak specifically to the coronavirus pandemic that we find ourselves. I would argue that there are three important constructs as we begin to engage and manage this pandemic. One is the physical environment. The physical environment, where you work or where you distant from work, has to be safe, and it has to have those guarantees, those public health guarantees that allow people to be comfortable in where they work. So the first important one is the physical environment. In public health, we talk about that in the larger context of that's which you can construct to assure your health is the best it can be. And as we try to reopen, if you will, I think there's some not well thought out strategies around the physical environment. If you look at how we opened in Georgia, opened with barbershops and beauty shops, that seemed the worst place to start to re-engage with community. So the physical environment is the first construct that's most important. The second one is the behavioral environment. People know far more than what they do. And this continuing increase in the pandemic is based upon, I think, human behavior. People know what to do, they're just not doing it. Wearing a mask, as the science is evolving about the importance of that, we know without the data that wearing a mask is critically important. As we're measuring outcomes, we're finding how important that mask is. So wearing a mask, and that's part of behavior. Going to the right places or not going to the right places. There's a tremendous amount of challenge with staying away from places that you know place you at risk, both not so much in the work environment where you have no choice, but in the social environment. They open the bars, they open the clubs, they open the social interactions. And so it seems to me that we have to manage, understand behavior, human behavior, and that's a science to that. There's a science to understanding what motivates individuals and groups to do things and not to do things. So let's reduce the issues around behavior beyond knowledge, beyond attitude, but really begin to engage the science around how do we influence human behavior. And that's important. And that's particularly important with the church, the faith community. How many churches are having virtual services? Many of them have the capacity and still choose not to have those virtual services. So we got to some kind of way understand scientifically how do we influence population behavior. We've got the first and most important, the physical, and then the behavior, and then the language. The language, something as simple as the difference between social distancing and physical distancing. That's language. How do we frame this conversation? Understanding the difference between a public health crisis and a medical crisis. And if you understand that difference, you've seen we've gone from a public health crisis to a medical crisis, and now we're in the midst of both. So those three constructs, I think, can be very helpful. The physical environment, the behavior, individual and collective behavior, and the language. And the language is critically important. How do we frame what we want to do in ways that people can understand? I think that's a strategy to begin to build trustworthiness and to better engage folks around this pandemic.
Thank you for that, Dr. Warren. And we have another question from Dr. Charles Moore. His question is, how would you suggest that we educate the faith community, barbershop, hair salon, and etc. to fully understand that they should be equal partners in all aspects of any engaged work? Are there any particular strategies that you've seen that work best?
Yeah, I think you have to understand the structure, the cultural structure of the faith community. And I would suggest, regardless of denomination, and my experience has been within the Black faith community. And I think if you understand that hierarchy, then you don't go to local congregations, you go to faith leaders and allow the faith leaders to share what the congregation ought to be doing. You don't go to the congregation. You don't show up at a church or a faith place asking for something without getting the kind of condolence and the concurrence of the leadership. Start with the leadership and don't challenge the leadership. Start with leadership and ask the empowering question. And once they are convinced, then I think it will flow downstream. I think the whole question of educating, has to be distinguished from informing. People know more than you think they know. So I would start with the question versus the answer. Don't try to tell us what, ask us what. So it's a paradigm shift. And I think it must start with even understanding the difference between how the faith community thinks, if you will, versus the general population. And once we understand that, I think we can work it much easier.
Thank you. And Dr. Ted Johnson has another question. How has public health always been political, and in what ways is it better or worse now?
When I was in graduate school many years ago, the premise, the mantra was public health starts with the political reality. And that's what we start with. And that is who controls the resources and for what way do they control them? So I would not see the political reality being necessarily a negative. That's the place to start the engagement. And without it, things don't change. Not the theory, but the practice. So I would see the political reality as a tool to advance public health. And you cannot do it without it.
Thank you. Do we have any other questions before we conclude our webinar?
So can I just follow up on that last one, Dr. Warren? And so
Sure.
Thinking about the political reality. And so let's say that I'm very concerned about our prisons and jails. And I live in Georgia. And I think that prisons and jails in time of COVID have an unethical quality to them that transcends the usual unethical way in which we use incarceration in this country. So is it right for me to write to correspond with the governor and say, you know, dear governor, we need to protect our prison guards from COVID. And we can protect our prison guards from COVID by releasing prisoners, when actually I'm concerned about everybody. And so it's just one of those things I've been thinking a lot about in my mind, because my concerns are broad, but the political reality in Georgia might be that our governor doesn't really care much about prisoners, but he does care about custodians and cafeteria workers and correctional officers. And so help me think about this a bit more. Thank you.
Yeah, I think the what is your goal and what is your strategy? Because if people get the two confused, then you can have doing the right thing for the wrong reasons. Just the premise of you want to release incarcerated people to protect your guards. Is that a strategy? Or is that a goal? Because it says to me that you're not concerned. If it's a goal, then you're less concerned about the incarcerated than you are of those who take care of them or are supposed to take care of them. And it also is found much broader premise of who's incarcerated and why. And so I think to mix a strategy with a goal is shortfalled. And out of that, I would raise the question of, let's talk about incarceration and the private and prison incarceration system. And so you start with that fundamental premise, I think, and then move to strategy and then implementation.
So in that scenario, my goal may be to get people out of prison who are at no risk of being released. But if that's my goal, my strategy might be to focus on the common political belief.
Yeah.
Did I follow you correctly?
I would start a little more fundamental than that, not who's incarcerated and why, who should be incarcerated and why. That steps it back a little further than getting them out. So it raises, for me, it raises a fundamental principle about the criminal justice system that is in discussion right now, and hopefully something better will evolve.
Is there any other questions or comments or concerns?
Let me raise a question,
Okay.
if you will. How are you all reacting or acting, if you will, with the work you're doing in this context of the coronavirus pandemic? How are we dealing with Alzheimer's disease and its consequences in the context of the coronavirus pandemic?
Anyone want to take a stab at that question?
My question must not have been clear. May I ask it a different way? How do we respond in the best interest of elderly persons who disproportionately are at risk for the coronavirus pandemic? How do we respond to their risk in the presence of this crisis?
This is Carolyn Eggman, and when you first asked the question, it was more general. And I thought that you might be interested in knowing that the Urban Health Initiative is working on a virtual doula program. And that means because most hospitals will not allow more than one person to be with a woman during labor and delivery. And if that person leaves, they can't be replaced. So we're working on a program where our doulas are learning to work digitally, working with the birth support person as well as the woman.
Okay. What I'm suggesting is that beneficence, we've got to do something, and we don't have the option of not doing something. So what do we do? What do we do?
This is Rebecca Dillard. Much like Dr. Aidman's program and what Urban Health Initiative is doing, but on the other end of the aging spectrum for our Alzheimer's patients with Georgia MemoryNet, leveraging technology, digital outreach. I see on the participant list a lot of our partners from our memory assessment clinics and our area agencies on aging. And I think all of us can say we're have a heavy lift of standing up telemedicine, remote cognitive assessments, and then also remote connectivity with the area agencies on aging to try to continue the community services and supports. We've also partnered up with the School of Nursing and some folks in the Brain Health Center at Emory to develop a caregiving during crisis curriculum. We've also got our communications team partners on here as well who might speak a little bit to what we're doing there, but it'll be a blend of everything from podcasts to formal curricula to downloadable materials that are focusing not only on, to your story earlier, Dr. Warren, about the patient who is taking his mask off with Alzheimer's. How do you help manage that if you're a caregiver in the home or even remotely? What are those types of strategies you can use and deploy, as well as how do you even navigate this virtual healthcare system, right? We know that navigating the healthcare system is like, to say it's a burden is a massive understatement. And then you take this whole healthcare system and put it on a new virtual platform. So how can we help people navigate that system? I think that's, the broad stretch of our approach. But even then, you've got folks who are in rural parts of the state who don't have access to that technology and broadband. So we're at a point right now where we're really trying to look hard and deep at for those folks who don't have internet, don't have computers. How do we reach them? I think that's our biggest challenge right now at this point.
Let me say what I heard, which is very encouraging. You're not trying to develop a new normal. You're trying to create a better one.
I like that.
Yeah, because I hear the notion new normal, get back to the way it was. The way it was wasn't good.
Right.
You see, so let's talk about, why don't we envision an optimal or a brand new, which shifts the paradigm from relying too much on what was to what ought to be, infusing a vision of what ought to be in opposed to relying on what was, because what was wasn't working.
Yeah.
So that's what I heard, and if I heard correctly, that's exciting. Other thoughts, other excitement, and as we started off in the coronavirus pandemic, folks didn't know. They did what they thought might work. So what are your thoughts about might work to make what you're doing a better than the old normal, even a new normal?
I think that one of the things that comes up a lot is what happens for medical care between the times that you're in the clinic. So if you go see the provider 4 times, that's great for for those 4 days, but what happens at other times. And I think that one of the lessons of coronavirus, as you were describing earlier, is that one day somebody may be fine and then 4 days later they may be dead. And so this notion of how we keep a close care and a close touch with people when they're not right in front of us has been one of the things that we've been working on. Thanks.
Yeah, absolutely.
And Katie Howard wrote in the chat box, anything that can be done to make rural areas more accessible for telehealth, distance learning, etc. This also applies more suburban and urban areas because of lack of equipment, skill, and money. Do you have any other questions or follow-ups to Dr. Warren's questions? Did you have any other questions before we close out, or any challenges or words of wisdom before we conclude our webinar, Dr. Warren?
The whole notion of hosting webinars is an ideal strategy that should increase, not because of the coronavirus, but because it works. And hopefully we're building relationships, virtual relationships that evolve into better strategies for each of the things, all the things that we're doing individually. And the more we share, I think the better we collectively become. And the fear of saying the wrong thing is a misnomer. The fear of the wrong question is a misnomer. So I'm excited to talk with you. I hope we've had a conversation, and I look forward to continue to work with the Urban Health Initiative and any of you, all of you that are trying to do the right thing for the right reasons. So thank you.
Thank you, Dr. Warren. And thank you again to Georgia MemoryNet for hosting these educational workshop series, which I personally enjoy. And thank you to Urban Health Initiative for co-sponsoring this event. You will receive a survey after this webinar, and it's highly encouraged that you provide any necessary feedback. For those associated with Georgia MemoryNet, the next webinar will be held next Friday on July 10th at 7 a.m. The topic will be expert guidance on challenging cases and ambiguous diagnosis with Dr. Law, Dr. Hells, and Dr. Lori with Georgia MemoryNet's MAC core leads. And again, thank you everyone for participating and joining us today.
Thank you.
Thank you.
Thank you. Thank you.